Wonderful, Anu. Go ahead. Tell us what are you going to do now?
Pedro Moreno and Michael Kim, hello. So I have Joe Sweeney with me. He's going to talk about this case.
Yeah, so this is a 84-year-old gentleman who's had a prior 3-vessel bypass in 2005, a known patent limit to his LAD. On his last catheterization that was done about 2 months ago, we found that his vein graft, jump vein graft to his LPL to his PDA was occluded. He underwent a drug-eluting stent to the ramus and the proximal circuit to the left main at that time. And then he's coming back now today to a high-risk road ablation of a tortuous RCA.
So if you see here, you can see that we actually opted for radial because of his BMI. BMI is about 35. So you have very tortuous RCA, but if you see there is calcium proximal, but most of the calcium is probably in the mid RCA. You see that? In the mid RCA, and the disease actually was not, during the previous cath, the flow was normal, but today if you see that after the mid RCA, the flow is almost TIMI 2 now. So we're still going with the plan of doing rotational atherectomy. So what we did, this is a guide that has been selected, so we can get a good support, and we did a fielder fine cross. We have the rotawire. So we have the rotabar there of 1.5 rotabar, but the question is the same. And when I'm trying to go forward with the rotabar, you see that the guide is coming out. So this is something we want to show, that in this situation, what you'll do, that you will do a dyna and get the rotabar inside. So with the new, if somebody can show here the hands, how the new dyna will work. So you press the dyna button, and then what you're going to do is, here, this is the only thing that's a little, you have to break release dyna, and then I'm advancing with my left hand, I'm going forward. That's what was done.
And this is a 1-2-5 bear?
No, 1.5.
1-5, okay.
So that way, by doing that technique, the 9 centimeter of the rota length is not lost. If you had not done the dyna the way I showed you, and you're doing dyna using the knob, you lose your 1 to 2 centimeters here, the length that you would need to, if you needed to do the rota. So now you have the full 9 centimeters in your hands, and that's how we are going to start. We already did the dyna, so I'm just going to go off dyna and start the rota.
So, Anu, in comparison with the pedal rota that we used to do much easier, just summarize how you did it again.
Okay, let me just finish this. So actually, if you think about it, 1.5 is a small for the proximal, but it is the right burr probably for the mid to distal RCA. Okay, good. So 23 seconds, that's what Henley is telling me. So I'm going to stop, wait. You can see the hemodynamics, blood pressure is good. And the plan here is the same. Since we're not going to go groin axis, we do not have a pacemaker, but the nurse by my side is ready with the aminophylline if the...
You're still giving the same cocktail as before?
Yes.
Because of the flow, you're not concerned about anything? Okay.
Yeah, the fact that the angiogram recently was TIMI 3 flow suggests that this progression to subtotal is very recent, and therefore the chances
So you can see that, Pedro, because of the dyna
Yes.
I was able to take the rotabar all the way down.
Absolutely.
Yeah.
That's a beauty.
Going back to the same technique, how would you use your dyna technique? So you can show my hands again. Same. What you're going to do is your knob has to be tight here, so that is not going to move back or forward. Then you're going to go dyna. You see that? This is the dyna button is on. But then with the pedal, remember we used to have dyna button on and then you press the pedal. But instead you have a new button here. So this is the brake release has not changed. So you will press both because you need to release the brake. So the burr is free on the wire to move. So you do the brake release and then you will go, see my left hand?
Yes.
Manually I'm going forward. So that is the technique.
Got it.
So now we are
very
done.
important. For the operators in the room, this is crucial because when you have distal calcific lesions, you have to advance your burr on the dyna, otherwise you won't make it. Difference with the orbital atherectomy, which is much easier in that regard. So let's see the flow now. I mean, you
Yeah, I
cross.
We crossed, easy.
you a good guiding
and
support.
if you see that that's EKG is fine, so likely the flow is okay.
Oops, off.
And the guiding sits much better now.
Yeah, look at that.
Look at that. Yeah. So the question is, I think we can now take a, since I think the tightest lesion and most of the calcium was in the mid RCA, we will do side-by-side burr.
High pressure.
Side by side we will do a wiring, and then we will just go high pressure balloon and take care with the stent. Agree?
Agree. So you're going to plan to stent from the mid distal up to the ostium.
Yes, and we have a high pressure balloon which is a 3.5, 20, 30 we have.
3.0. We have a 3.0.
Okay, open a 3.5.
3.520.
Because the vessel is large.
And C.
So the side by side I'm using a run through wire. It's like an early bifurcation, but now you have to make sure you go into the AV continuation to RPL. Yes, good. So I'm going to leave the rotor wire there, so it will help us as a buddy wire to get our device down, and we'll take it out when our first stent has been delivered. So the guide selection for this kind of tough RCA. So if you're doing a radial, is same. Akari is another guide that you could use, which gives us a good support versus Lima versus AL 0.75. Now, if you have proximal disease, or you have ostial disease, AL 0.75 may not be the good guide. Go up. Since like this case, the guide tip is already sitting in the lesion, but is giving us a good guide support.
Do you have any thoughts about the fact that it was TIMI 2 flow? The conventional wisdom, of course, is to be cautious about atherectomy when there's already TIMI flow that's low because of the potential for further degradation of TIMI flow from the atheremboli.
Yeah, I mean, this same question was discussed during our first case in the morning. Same, the case had a normal flow, but when he came today, had a TIMI 2 flow. So, I mean, as long as we know, you're very careful. Now, one thing we could have actually, fellow Joseph here did discuss that should we have gone with a smaller burr size, but then it would have been too small. That's one thing that you can say, that if you have TIMI 2 flow where you think it is because of thrombus in the lesion, you do not want to use rotational atherectomy in that situation. But if there is a lot of calcium, you could go smaller burr, which could be 1.25. But we felt that, I think if we had the technique, if you do the right technique, the way we showed it, should be okay without any slow flow.
So Anu, taking advantage of our prestige board here in the table, and because we have done every single case, we have done rotational or orbital atherectomy today. I'd like to start with Dr. Ball. Tell us a little bit, would you have done this case without atherectomy?
Looks difficult. I would have done the atherectomy.
So anybody on the panel that will disagree that this procedure in this specific case make a complex simple, or the opposite?
I think it's justified to do. I mean, we are underusing atherectomy devices for calcified lesions. There are definitely calcified lesions. So I don't see. What I was missing here, I didn't see pacemaker on a right coronary artery with a slow flow initially. So maybe, Kenny, you want to comment, why didn't you use pacemaker here?
Oh, only because then we have to go to the groin again.
Well, you can do brachial.
Brachial, you mean, antecubital.
Or you can do jugular pacemaker.
Yeah, agree. But we felt we probably will use pharmacology to do that rather than give an extra stick.
Synergy, that's fine.
What did you use?
Just to counter the roto and debulking, when your vessel's this big, I think you deceive yourself, number one, how much you do roto, and number two, you can get away with a lot with high pressure ballooning and stenting. They tend to give you a good enough lumen to get out of the room, even if you do get stuck. But really, I think, we do underuse roto, but roto really is important when the vessel size, you don't have a lot to work with.
I think this is a beautiful example how the audience, specifically for the young interventionalists, needs to master rotablator. It's a key. When you have mastered this technique, then you can go to orbital. Don't do the opposite. Because in the real tough cases, you're going to need rota.
Yeah.
However, if you only do orbital, then when you have a real tough case, look at that orbital that Kinney was doing, and the stent didn't go after orbital of the mid LAD. So master your rotablator technique, then go to orbital, which is much easier, and finally, as a seasoned, experienced interventionist like John Fox on the table said, you can even sometimes go ahead and balloon in big vessels because the stent will open and the big vessel will allow you to do that.
So Pedro, I would submit to you that majority of operators in the world would not use any atherectomy here. They will just use a balloon. I'm not saying that this is the right thing, but the reality with 3% atherectomy use this is an anomaly what's happening here in some institution that you see so many cases. But the real world, it's only 4 or 5%. So I think that most operators just going to go with the balloon here. And the other, I think in few years, everything is going to change again because with the shock wave, people will use it much more. They'll feel secure because it's almost free of complication that we see. We don't see perforation, distal embolization. So I think the world will change again, maybe to do more treatment of calcified lesions with other devices, which will help maybe to atherectomy, but I think it would be transformation to use more shockwave-like devices to treat calcified lesions.
Why is that? Because the technique is difficult to learn? Or?
No, shockwave is actually...
No, the atherectomy. Why
No,
is
it's not.
gained?
It's not difficult, but everyone who used it had at least one perforation or one dissection
That
or one
makes them
slow flow.
cautious.
And if you think about, there is a whole new generation. They don't do much, and they feel unsecure to do those procedures. Now, if you give an alternative of a device that help you to crack the calcium without any of those complications,
EKG
you will
is-
default in something which is conceived to be safer.
You may just want
I
to
think
pull
you're
back
right.
your
I think
guide if
shockwave will
EKG.
dominate once it's available in the U.S. It is a little difficult to deliver. That's the only sort of
Well, you can do
challenging thing. But
predilatation
yeah,
with
but
2
there-
millimeter balloon.
Certainly with good guide support and pre-dilation.
But with low flow, will there be any?
The wire.
No, it's not an issue.
They run through a fielder.
You know, we are in the Disrupt trial. We've done a handful of cases, but it's amazing what you can get with few seconds of inflation of the balloon and delivering the low-frequency ultrasound waves, and the balloon is fully expanded, and you're done. I mean, so I think looking on what the main reason people are not using it because they feel insecure. It's not about cost because rotablator doesn't cost much money.
No, I mean, your practice will change
You have
with
it
the
already approved,
shockwave
right?
because we have shockwave. And honestly, I mean, rotablation clearly is still an important clinical need, but the first step now is shockwave.
That's the
Because
step.
after the shockwave, if you are not happy with the result, you can still do a
can still do
rotablator.
rotablator.
And there is the other thing. You don't need to take out the wire on the side branch with the shockwave. So if we are doing an unprotected left main, for example, or an important diagonal and LAD, you can keep the wire in the side branch. Indeed, you cannot do with the rotablator, no?
I know I see a lot of advantages to that. This is becoming a disruptive technology
Yeah.
for treatment calcified lesion. But the good thing, more calcified lesions will be pre-treated correctly.
And there is any follow-ups, like at least 12-month follow-up on these severely calcified shockwave lesions treated? Dr. Schufel?
Yeah, you know, there is a registry that have been ongoing. There are some national registry ongoing. Clearly, we have still to demonstrate longer-term follow-up because at the present time, most of the results are at 30 days. I mean, it's not longer-term
Exactly.
follow-up, yeah.
Yeah, this is crucial because the incidence of MACE in every trial and even in meta-analysis for calcific lesions is up to 23% at 1 year. And you have MI and death also significantly increased when compared to no calcific lesions. So calcified lesions, severely calcified lesions are not easy at the long term. They're easy to treat with mastering techniques as we've seen today, but the long term is what it counts. So
AK, can you put it's Mike Kim, how are you? I find that putting a guideliner for these cases are are very helpful. I usually just do it right after the rota. I just have one just prophylactically. I think, in fact, now I use much less aggressive guides because of it. In this case, in addition to a wiggle wire.
Wiggle wire is an old wire. I tend to do that before I would do a buddy wire. I used to do buddy wires first. But
Yeah, this is the radial support.
Yeah, she's enjoying again the
Believe
radial
me.
support.
Yeah, if we had groin, I would be done and
by
doing
now.
the next case now.
I can get you a
But we
groin.
know-
but if you
With
just use a
ultrasound stick,
Godzilla,
you
I
can
think
do
you'd
it.
be set.
We do
I support Mikey's
95% by
comment. I
radial.
think the Godzilla or the guy liner here
we
is.
may need
I would agree that I don't really wait anymore to fail.
Yeah,
I just sort of put it
I just
down
have it.
and do it primarily.
It's
And
easier.
the vast majority of our sort of high-risk and/or referred surgical turn-down cases, they all require a guide extender. You might as well just get it out and open it up and start using it.
Which is a big concept for
get us
calcium
a-
because it
Get a
seems
guideline.
that we're seeing more and more calcium because the population
Or
is
a
just getting
Godzilla, open,
older and
open.
older. And we do more 90-year-olds,
French,
and
seven French.
calcium's going to be an important player.
Has anyone
Lady?
used this new
Give us a-
Medtronic guide extender? Apparently it just came out.
But I need a balloon,
Balloon
right?
that one first?
Yeah.
So anytime I
What's the
see a
photo?
sternal
Yeah, give me the
wire or
450
two, I
high
think I'm going to
pressure.
need a guide extender.
The other thing you can use in this case, you still can anchor in the RV branch like the case before, because there is a nice branch there as far as I recall. I mean, I don't see it right
But
now.
I think the entire day we never used a guide liner, Godzilla, guide extension. So let's use it right now. So but what I'm going.
Now you have
Hey,
two,
hey,
wi-
can
you
you
have two
overdue.
wires, huh?
Can you show the technique where you
Yeah.
balloon anchor it and
Yeah,
then?
that's what I'm going to show. So it's a 7 French guide, thinking that if we needed a larger bar, that we may needed a 7 French. And so what is going to happen? So we will have 7 French guide liner. So same, is my hands being shown now?
No.
So both the wires have to go in the guide liner. Both the wires. Don't leave
We
one
need,
outside,
we need
one
the
inside.
we need your hands
Can
on
you
the
show
screen.
the hands? Are they being shown?
And this, you're using the 7 French guide
Only because
liner?
it's a 7 French guide, not
Yeah.
because we need it.
Which
Yeah,
guide
you
liner?
could put a 6 French guide liner inside. But I think if you have a 6 French guide liner, 2 wires and a 4 stent will be trouble. So
Exactly.
what I'm going to do right now, what I'll do is I have fielder wire as well as a run-through wire. I'll go on the fielder with the balloon, anchor, go distally, and get the guide liner in. Yeah, I mean the Godzilla.
Then you
Suck
could
it
just
in.
literally unsheath
Yeah,
the
there's a
stent.
difference there, by the way.
So
A
why do
guide-
you
a
use two
Godzilla will
wires
take
now,
the
for
two
the
wires
guide
with a
liner
balloon.
or for the, once you pass the guide liner?
Sorry?
Why do you use now the 2 wires?
Oh, no,
is
because
this
I
is-
have it, that's it. So even
Oh,
then,
because
this
you
is
had
not
it,
going.
okay. But you can pull one of them out.
It's not going at all.
You already stented the mid segment,
I
so
know.
the issue is here, the strut of that stent is giving the trouble and the angulation.
Okay, good.
So,
Okay,
Can
go-
you put
good,
the
all
guide-
right,
good,
now we're talking.
good.
Usually you can just sort of inchworm it
High
along
pressure,
too. You can
high
take the Godzilla up and bring it right to the back of your balloon
Yeah.
and then try to move it down sequentially. You can also
This technique
inflate it
is so
too
helpful,
if
what
you
you
get
just
stuck
showed.
like
We're
that.
done, yeah.
So that's a
Okay,
very
next,
nice
next
technique.
case.
Next case, I have to start, so.
No, but that's a nice technique to show how you can deliver the guide liner over the balloon.
Okay, get the stent now.
And that is the way to do it. I mean, because this device can give you dissections, and when they are dissections, they're very bad dissections, specifically left main. And so always use your balloon ahead, inflate the balloon, go slow, don't rush.
And try not to avoid injections with the
No,
guide
avoid
liner deep in.
injections.
Yeah.
Don't try to give injections because you may have damped pressure and sometimes ST elevation. So
Yeah, you don't
do
need to
not
give
lot
injection
of-
here.
yeah.
You know where
no,
you are.
No, should not be giving injection through this.
The nice thing
fellows.
also, if you cannot deliver the guide liner distally, you can do little pieces with the balloon ahead of it, inflate, deflate the balloon, and that will allow you to deliver the guide liner to
That's
the
exactly
final
what I just said,
destination.
but the other thing is you're always going to get it, you generally get ischemic too. As you can see, the STs are going up. Your pressure's
Yeah,
damped
it's important to
naturally
have the
because of
stent
the
ready.
mother-daughter relationship there.
some
But
guy now.
it's a time when you got to really move kind of quickly to get your stent down and then pull back and reperfuse.
Okay, now,
What is the length of this stent? 28?
yeah, yeah, just okay, some die. Okay.
Yeah, better to deploy
I'm
there
going to
and
pull
put
the,
something.
yeah, I think we're
Guide-
just,
Your guide
just
liner's right
okay.
there.
Yeah, some die.
Just a little millimeter more.
I think you're good. Yeah, go up.
Going up.
Pull back the guide.
Pull the guide.
Yeah, no, I will. You go up, then I'll come because I pull the
Okay.
guide, stent will come out. So as he's going out, then I pull the guide out.
All right.
Uh-oh.
Just the guide, not the
Got
stent.
it. It's out.
Yes. So that's other technique. Never pull the guide out. This is typical fellows do. And then what happens? The stent comes out as you're going up. So you dilate it. As you're dilating, then you take the guide out slowly. Okay, go up again. So now they can post-dilate it. Are we going on to the next case now?
Yeah, we should. That will be case number 11. Which room is that?
Wait, I have to go there.